And welcome to the Pulse of Manatee, brought to you exclusively on Manatee Educational Television. I'm your host, Dr. Srini Iyengar, a cardiologist at the Bradenton Cardiology Center. Did you know that nearly 600,000 people die of heart disease in the U.S. every year? Just think about that. That's 1 in every 4 deaths. February is Heart Disease Awareness Month, and we have gathered an expert panel today to discuss how to maintain a healthy heart and to watch for the symptoms of heart disease that may otherwise go unnoticed. All right, guys, thanks for coming here today. I'd like to introduce first and foremost Dr. Bob Kozer, family practice physician. To his left, Paula Jefferson, RN, extraordinaire RN of Manatee Memorial Hospital. And to her left, Dr. Jose Polanco, internal medicine physician, also here in Bradenton. Guys, thanks for coming in today. So February is Heart Disease Awareness Month. Bob, I'm going to ask you straight up off the bat. Patient walks into your office, smokes, is diabetic. What are you looking forward to in working this patient up towards a heart vascular problem?
The first thing I do for patients when they come in, I see what kind of risk factors can I modify. You can't modify whether you're male or female or how old you are, but if you're a smoker, that's probably the most dangerous risk factor you can have. So right off the bat, I tell my patients, please stop smoking. Are you interested in stopping smoking? And if they say yes, then there's several different ways you can help them to stop smoking.
Well, Jose, how much you comment on that? What do you think with people who come into the office that are smokers? What are the ways that you try to get them off those cigarettes?
Well, it's very interesting part because perhaps I agree that smoking is perhaps the most damaging, one of the most damaging conditions associated with diabetes, hypertension, dyslipidemia, peripheral vascular disease. But one of the ones we can modify immediately in the office is just about smoking. However, we need to remember smoking is not just a stop, it's also a psychological
addiction.
Addiction, because what happens is the acetylcholine receptors become attached with the nicotine in the brain, can give you a biological addiction. So what you have to try to do is link the cardiovascular condition is explained to the patient and say, listen, if you have peripheral vascular disease, you have stents placed by the cardiologist, it doesn't matter if I take care of your sugar, if I take your cholesterol, as far as you keep smoking, all this medication, all this management we're doing to you is going to be sabotaged by you keep smoking. So you have to make a link between negative consequence. You tell the patient also positive reinforcement. You have to tell the patient, for example, there's a statistic there that if you keep smoking, on average, you have a lot more years expectancy.
Exactly.
And so you have to give it some negative implication, but at the same time, you have to give it some positive reinforcement that the benefit the patient can.
And unfortunately, I think you're right. It has to be both a negative situation, but you also have to say, listen, this is the positive that might happen if you quit smoking. Now, Paula, what have you seen patients quitting before? What's worked for them?
Well, you really have to get the whole family support, and I think it's a whole family thing. You can tell a patient, but if his wife smokes or if the husband smokes and the wife's a patient, you really need support from your whole family of how to go forward. And medication works with a lot of patients. I know some doctors subscribe it, and you have to tell them, don't worry if you have to start with 4 cigarettes a day, then 3 cigarettes. But I always tell them, if you don't quit, you will be back. You'll see me again. You'll be back in this cath lab, and you might not be so lucky next time.
Well, let's talk about a little bit more, a subject that's been controversial. Bob, when you comment on this about electronic cigarettes, what is your opinion about that for helping people to quit smoking?
You know, electronic cigarettes do help people to get off of the cigarettes. The problem is that electronic cigarettes are probably 5 times as dangerous as cigarettes themselves. There was a study in Japan that showed that the vapors from electronic cigarettes had 5 times the amount of carcinogens that normal tobacco smoke has.
It's amazing because I think we're almost trading evil for another evil. You know, there's no clear-cut silver bullet other than trying to quit altogether.
Well, I want just also wanted to add, in terms of specific intervention, there's psychological support. The state of Florida has a 1-800 line that you can offer the patient where they can call for psychological support. Has been shown the most successful treatment option that we have there to offer the patient has been shown that if you use nicotine patch plus the gum together, they work pretty well to help the patient in order to prevent the withdrawal. We can use some bupropion SR, is another arsenal that we have available. Also, we have also Chantis, which statistically provide 40% improvement if the patient have the willingness to quit. And that provides 40% chance more for the patient to be successful as well. So these arsenals are available to us for the patient there.
Our take-home message for everybody watching right now is that there is support, there is help, but you have to start with yourself. You got to look in that mirror and say to yourself that you want to quit, because all these things we've discussed can only be done if you're willing to take them. So I think it's a first-line statement that smoking obviously is completely negative and will facilitate heart disease in the future if you keep doing it. So guys, let's move to the next big thing, next big risk factor. Diabetes. Bob, in your office, someone who's a diabetic, how do you make that link between blood sugar and bad outcomes with vascular disease? How do they, because most patients will say, so my sugar is a little high, I don't feel it.
One of the most important things to do is first get a hemoglobin A1C. If the patient's hemoglobin A1C is in the normal range from 4.5 to 5.7, they're not diabetic. Now, at 5.7 to 6.4, they're going to be pre-diabetic. Anything greater than 6.4 is diabetes, needs to be treated. My first line treatment is diet, exercise, and metformin. If they have elevated body mass index, then I'd get them to go on a weight loss program. And also, you want to check a urine test called a microalbumin. If their microalbumin is positive, that means they're exquisitely at risk for further cardiovascular disease, strokes, peripheral vascular disease, aneurysms, and all kinds of vascular problems.
Isn't it amazing, though, that patients won't realize that a ridiculous amount of complications can happen from diabetes when they're diagnosed? Because a lot of them just say, it's just a little sugar in my urine, so I won't eat sweets before I give a urine test. Now, Paula, how do you tell a patient that it's not just sweets, it's a dietary lifestyle?
Absolutely, and when you look at the vessels, especially under angiogram in the hospital, you can see how that sugar has, or diabetes has just worn on their vessels, and there's little, before anybody even tells you that they're diabetic, you can look at their vessels and see that they are damaged. So it's real important that people realize what it's doing to their body, not just, like they say, a little sugar in their blood or something, or in their urine.
And Jose, this is a meat of internal medicine family practice practices is diabetes. That comes a lot. So what do you say when these patients come in and they say, can I just eat less sugar? Why do I have to go on any medication? What's your response?
Well, it's amazing. One point I want to bring to the table is about the hemoglobin A1C. When the patient comes to your office and you talk to the patient, listen, your hemoglobin A1C is more than 6.5, therefore you are diabetic. If you don't explain to the patient what the hemoglobin A1C means, that is insignificant for the patient. So one of my jobs as a primary physician is to explain to the patient what the hemoglobin A1C means. It's the average of the sugar fasting and postprandial. And what happens is every 1% increase of the hemoglobin A1C that you decrease, let's assume the patient comes to your office with the hemoglobin A1C is 7, which is the average 154. Every 1% increase over that is if you decrease from 8 to 7, you decrease the possibility of cardiovascular problem for 43%, which is amazing.
It's amazing. Just from reducing the number, it's incredible.
Also, something I want to add is also the macroalbumin. Sometimes the patient comes to my office, we do the macroalbumin. The patient says, well, what does this mean, macroalbumin? Well, this is a good point that you bring to the table. Also, the macroalbumin, the patient has protein leakage in the urine, more than 30 micrograms in the urine. I explain to the patient and say, just by this finding itself, the possibility you have blockers your coronary arteries 50%.
Unbelievable.
The statistic, any patient with positive macroalbumin, if you do angioplasty or stress test, statistically 50% of those patients have the potential to have CAD.
It's amazing.
Which is amazing.
It's amazing. And on top of the diabetes and the smoking, now Bob, what's the next big one we have is cholesterol. Again, another one that people don't feel. So another way of how do you explain to a patient, because I can tell you I've gone through this 100 times, Doc, can I just eat oatmeal? Can I just walk further? Your LDL, which is a bad cholesterol, is 250. You have all the risk factors, but they don't feel it. So how do you convince a patient that, hey, you do need to be on something for this?
Well, Cholesterol is a controversial issue, as you know.
Yeah, of course.
The very best treatment for high cholesterol is the statins. And statins have been proven to reduce heart attacks, strokes, and need for bypass surgery. If a patient comes to me and their cholesterol is just a little bit high, I take a look at other factors. I take a look at their blood pressure. If their blood pressure is greater than 140/90, then I treat their blood pressure. If they're overweight, I look at their body mass index and get them more active with exercise. If their cholesterol is greater than 200, that is a risk factor. If their LDL cholesterol is greater than 100, it's a risk factor. And if they're diabetic, it's important for their LDL cholesterol to actually be under 70.
It works
That's
in
the goal.
conjunction, and that's what I think everyone at home should realize. If you have high cholesterol and diabetes, you're actually more at risk, so you have to be treated more aggressively. Now let's add to this, on top of it, another risk factor. Paula, why don't you comment a little bit about blood pressure? How important is blood pressure control in this whole situation?
Absolutely. A lot of people don't realize they had high blood pressure and they don't check it, but that is something that you can control. If you take your medicines, you exercise, you do what you're supposed to do. So it's very important that people have their blood pressure checked, they go to their doctors, they take their medications, and they do what they're supposed to do. So.
Now, Jose, we've talked about this previously, but I think this is an important topic, and I think it's one of those where the big taboo of patients not being comfortable talking about it when they come to the office, but it's a sign of vascular disease, erectile dysfunction. I can't tell you how many patients come into my office and will never complain about their cholesterol, their blood pressure, their sugar, or smoking, but the one complaint is, I have had some issues and the spouse will have to push them along to say it. How do you relate erectile dysfunction and say, well, maybe this is actually related to all these risk factors?
Absolutely. Just the erectile dysfunction by itself, in many instances, precipitated by organic cause. So if all these factors that we mentioned before, hypertension, diabetes, dyslipidemia, high cholesterol, all produce damage in the microcirculation, which is fundamental for you not having erectile dysfunction. So that patient itself, by telling that, is a trigger for me to searching for risk factor for cardiovascular problem. Then I start looking for that, make sure the blood pressure, the sugar, cholesterol is in optimal condition. This patient, it does some screening tests for them.
Yeah, Bob, do you feel the same way that sometimes the patients will only have that as a complaint and realize, oh my God, you have these many more risk factors that we have to address prior to that?
That's right. In fact, if someone comes to my office complaining of erectile dysfunction, that is a red flag. So the first thing you want to do is evaluate that patient for possible coronary artery disease, peripheral vascular disease, diabetes, hypertension, and it's a reason to do a complete physical examination, lab work, EKG, and probably ultrasound testing as well. In fact, all of my Medicare patients usually get an aorta ultrasound. Medicare allows for that to screen for aortic aneurysm. I know you and I have had several different aneurysm cases together. I check the arterial system in the legs to make sure that the pulses are adequate, and if they're not, I do ankle brachial index testing. I do echocardiography if there's a heart murmur, because I want to find out what is causing heart murmurs in my patients. I check the carotid arteries for bruits, and if there's a bruit, I do an ultrasound test as well.
And I think the fact is people often think, oh, it's a heart month, that means it's just my heart. But they fail to realize that peripheral vascular disease often signifies that there might be more centralized disease in the heart itself. And the fact is there's so many other risk factors that obviously need to be addressed. It's a systemic process. It's not just one thing. Now, we have to go to a situation where if you have this patient with these risk factors, what are the symptoms that they should be concerned about if they have these risk factors now that we're trying to modify them when we know that something is developing? So, Jose, when a patient comes in and says, I have this complaint, how do you know that, hey, this might be a symptom of something worse?
Well, it's just basically you need to go for every risk factor. Sometimes it basically comes to you and says, I have some shortness of breath when walking 100 yards. It's some tightness in my chest. So this is a patient basically that you have to be searching for underlying CAD. Sometimes they come to you after walking half a mile, he start having cramps in the leg. That's a sign that perhaps the patient have peripheral vascular disease. And in most cases of patients with diabetes, they come to me with manifestation of the sugar to be high, and people where the sugar be, especially when the sugar is more than 200, behave like a diuretic. So the patient is going to start noticing urinating more at night, 6 times per night. They start losing weight. They start craving for sugar more than normal. They start drinking a lot of water. They come to those symptoms, they didn't realize they had diabetes already. So basically, based on the presentation the patient give it to you, you start searching for those conditions that we have normal protocol to proceed looking for.
Well, that's key that you mentioned that too, the shortness of breath, the cramping in the legs, because people always signify that, well, I always read that elephant on my chest, left arm pain, jaw pain, but that's, let's be honest, history was written by white males most of the time, and we are leaving out minorities, we're leaving out especially women. So Paula, comment on how women sometimes present with chest pain or a heart condition.
And in the past, a lot of women have been ignored because their symptoms are vaguer. They just come in with a tiredness, a weakness, they just general malaise, they don't feel well. And the doctors used to kind of think that, they're
Stress.
just complaining, it's stress, too much stress. And so I think people are aware. There's a lot of education out in the community, American Heart Association, physicians are aware.
And you're wearing red today as well?
Absolutely. And so I think more women are becoming aware. It does affect all of us, and so we need to be aware of the symptoms.
And that's a great message, because I want everyone at home to realize that women are an under-treated part of the country here for heart disease, because a lot of times we have historically been taught in medicine, the elephant on the chest, the left arm pain, the jaw pain, the individual on the golf course having the heart attack. Let's be realistic. The fact is that heart disease affects everyone, and actually is probably the #1 killer in women more than breast cancer.
Absolutely.
And that's why it's so important that if you're a female and you have any of these symptoms or risk factors, that you do see your physician as soon as possible. Now, guys, let's go back to something we can't control. How important, Bob, do you feel family history is in the workup of these patients?
Oh, it's extremely important. I try and get a good family history on each patient, especially if they come in with diabetes, high blood pressure, high cholesterol. If a patient comes in and they have those problems, then if they have a direct relative that has had a heart attack or a stroke, then they're probably 50 to 75% more likely to follow in their footsteps.
And that's huge, Bob. I'm sorry to interrupt, but I want everyone at home, that's a great point he just made, because you really should know that you are closer to your family than anybody else in the world, and their genetics are your genetics. Bob?
That's right. And another point that I wanted to make that Paula was saying is that women often have atypical symptoms if they have a heart attack, and they're harder to diagnose because they might not present with chest pain when they have a heart attack. They might have back pain, they might have jaw pain or just shoulder pain. It's very atypical. And the scariest part is that a great many heart attacks are missed completely because we fail to diagnose them, and it's a huge liability for doctors.
I totally agree. And Jose, the diabetics often have these neuropathic issues, so they don't feel the pain oftentimes.
That's a good point. 25% of the people who are diabetic have a heart attack without no chest pain whatsoever. So in this patient, the manifestation might be more feeling tired, fatigue, shortness of breath, rather than chest pain. So it's good to the community to know, especially the huge community outside there who are diabetic, they may have a heart attack and perhaps doesn't have the typical chest pain because the damage induced by the diabetes to the nerves. So therefore, the body don't register the chest pain. Also, I want to emphasize the female patient, they have the protection for the estrogen when they are in the early age. However, when the female become menopause, because they don't have the protection for the estrogen, the incident heart attack or CED is equal than men at the beginning when the female are young, because they have the protection of the estrogen, they have less incidence heart attack. But as soon as they become menopause, the incidence is equal or even higher than men. That's the latest statistic there.
And that's amazing because we know that there's a lot of controversy with hormone replacement therapy as well with these individuals too, with other forms of disease. But everyone at home now, I'd like to point out some things that we've talked about, some great risk factors. But what if you're one of those individuals that didn't have any of these risk factors controlled? Or what if you had the genetics but didn't have the risk factors and didn't know it? So what I want to show you at home here is a little model we have here onto my right here. And in this model, as you can see here, what we have here on the top is a normal artery. This artery itself does not have any plaque. You can see clearly a really nice opening in the middle here, which is where your blood goes through. And this is an artery that's located in your heart. Once plaque develops, you can see that on the side here, there is some plaque development coming in here. And what that does is encroach in the vessel lumen itself. So at this point, you can see that it looks about maybe 30–40% of the artery itself is being narrowed. Chances are you will not feel this. This is not where people develop angina. Usually when anginal or chest pain symptoms develop is usually down here. This is where the artery itself has gotten to about 80, 70, 80, 90%. There's only a little hole here for the blood to go through, and that area here is basically limiting the amount of oxygen to your heart muscle. We theoretically like to find people before all of this starts developing, but if we do find them, it's better to find them in this position here because clearly the muscle's still getting blood. Unfortunately, we find a lot of people down here at this level here, and this is where you see this redness that's right around here is basically where the plaque has ruptured into the artery, completely blocking blood flow. This is what we call a major heart attack at this point, and this is when we get all the troops assembled. We come in and we try to open these arteries up, but this is a life-threatening situation. So this is not the time to make a diagnosis of a heart disease. This is the time where we need to get the patient saved, but clearly we are working in backwards. We use the phrase, a horse out of the barn. At this point in time, the horse is clearly out of the barn. We need to go backwards and try to modify risk factors after the fact. Luckily, the way medicine works this day and age, we are lucky that we can treat a lot of these patients. However, our goal is to kind of get back to all the way here. If we know you have risk factors, we want to modify before you get to any of these levels, and that would be critical. So the main thing is the take-home message here is don't be down here. Let's try to get you all the way back here and try to modify as much as possible. And the big issue here, guys, is that we've talked about these risk factors, but I think people at home, everyone watching, it's, again, a lot of it's asymptomatic, the diabetes, even blood pressure. You'll notice a lot of patients come in with 170, 180 systolic blood pressure, but never felt bad, as well as the smoking, which is an addiction, and then you have on top of that the cholesterol, which they don't feel. I think our take-home message to everyone at home is that we try to treat the asymptomatic patients with the asymptomatic risk factors before you become symptomatic. So at this time, guys, I'm going to get some final remarks from everybody. Jose, would you like to start?
Well, so I just want to thank you for inviting me to the program. I just want to emphasize that modifying these risk factors is extremely important for every single person. Don't wait for a crisis to happen in the family. Try to come to your primary physician at least if you're not sick, at least one time for a physical, where you can be screened for hypertension, cholesterol, diabetes. To implement program exercise daily, that's going to prevent you many hassles in the future. You'll be able to enjoy your family without any major problem.
Great. Paula?
And I want people to know that this is a gradual process. This doesn't happen overnight. This plaque builds up over time. So you have time to change your lifestyle, to live a happy lifestyle, to live a healthy lifestyle, take care of your heart. You're in control of that. You can choose what to eat. Make good decisions of how you take care of yourself. Exercise, eat well, don't smoke.
Hey, Bob?
Most people that have coronary artery disease are asymptomatic. In fact, if you have symptoms, it's actually too late. The horse is out of the barn and the barn door is open. So go see your family doctor or your internist, your primary care doctors. We're at the forefront to prevent heart disease for you. Wikipedia says 1 out of 3 people in the United States will die of heart disease. Okay? Women, for breast cancer, 1 out of 11 will develop breast cancer. So just keep that in mind. Heart disease is the biggest killer globally in this world. So it's for us to help our patients to prevent heart disease.
And Bob, you're not only a talented physician, but a very talented musician. Why don't you take us home with a song here to finish off the show?
Well, thank you. I'd love to do that. I had possession over Judgment Day, if I had possession over Judgment Day, little woman I'm loving wouldn't have the right to pray. So I went to the mountain, far as my eyes could see. I went to the mountain, far as my eyes could see. Some other man got my woman, the lonesome blues got me. I rolled and I tumbled, cried the whole night long. I rolled and I tumbled, cried the whole night long. When I woke up this morning, my biscuit roller's gone.
Excellent, Bob. Thank you. Great job, Bob.
Thank you. Thank you for having us on.
Absolutely, guys. Thank you for all my guests for joining us today, and METV for making this show possible. When it comes to heart health, remember, when in doubt, check it out. And as always, remember, a positive mind is a positive body. We'll see you next time on The Pulse of Manatee.